Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 66 of the OBGYN podcast. Today is the Journal Club for January 2020, and to help me today, I want to introduce my two guests. The first is someone who's coming back to us, and that's Dr. Jillian Kurtz. Welcome back.
Hi, everybody.
And the second is a newcomer, and this is Dr. Caiyun Liao. She's a chief resident at University of Tennessee, and I'm very happy to have her here. Welcome.
Thank you. Happy to be here.
So this article was actually sent to me from Dr. Liao. So it is about the association between fertility treatment and cancer risk in children. It was published in JAMA very recently. And there's actually some interesting themes in this paper. It is a big data paper. Actually, a few years ago, I did a grand rounds on big data projects and how you interpret them. And maybe someday I'll put that up onto the podcast. But there are some things that we talk about there. And there's also some interesting statistics that I think Dr. Liao is very interested to tell us about. So we'll get into that. Before I get started, especially Jillian, since you're in this, when you read this paper, what were your initial thoughts? Like, where is this coming from? Is this something you've heard of before?
I actually hadn't seen this article until you guys sent it my way. Of course, the idea of does infertility treatment cause cancer is not a new concept, but this particular study I hadn't read yet. But overall, I mean, like you said, the Danish are awesome about creating these databases with lots of information, but I think we have to be careful when we're interpreting the results, which we'll get into in a second. But it doesn't seem very clean to me. They act as though it's really clean cut and easy to interpret, and I'm not sure that it's quite as simple as that.
Yeah. Dr. Liao, what were your thoughts?
I, first of all, respect the Danish people for having such a complete database on basically everyone in the country giving birth, everyone in the country filling prescription drugs, everyone in the country undergoing IVF, and also because, as the author said, the use of ART is free in Denmark, and so therefore accessibility is not an issue. So it is an awesome data set, and the authors, I can see, did a lot of work in linking, did a lot of work in analysis, which I myself have done in the past, and it is not easy. I respect their work, but I think it is problematic in so many different ways and so profoundly that while it may justify publication, it does not justify to be a JAMA paper, especially given the media response and how the society reacts to what they have said.
Well, that's a very interesting portion of this about medical research, and there's a whole sub-discussion here about medical journalism and how papers get, sometimes the weirdest papers get out into the public conscience. Let's save that for the end. We'll come back to that because I think that's a very interesting discussion. So let's jump into the paper a little bit. It is, like I said, the association between fertility treatment and cancer risk in children, published in JAMA from the Danish Center, as both of you said. Their introduction is pretty short, which is okay for introduction. I like short introductions. It basically says, I think what Jillian said is, we know that there are some issues here with IVF or ART and cancer, and they wanted to use their big database to look at it. So that's fine. As both of you said, these databases are amazing. In just this one paper, they used the Danish Medical Birth Registry, the Danish National Infertility Cohort, which is composed of the Danish National IVF Registry and the Danish National Prescription Registry, amongst others. So as Dr. Liao said, there is a lot of different databases that they were pulling together. A little easier in Denmark because each person does have their own identifier, a medical identifier, so theoretically it should be relatively easy to pull across different registries, but anyone who has worked with data knows that sometimes that's not true. So as you said, Dr. Liao, I think hats off to them for the amount of legwork that had to go into this. So how did they use these databases? I think that's where it gets interesting. So they also looked at the Danish Cancer Registry. So that's it's like the fourth registry if you're keeping track at home. And they wanted to look at what does the effect of infertility in general, having fertility treatments versus fertility drugs, and I'm going to ask the two of you about that in a moment, and then people who had no fertility issues, and then look to see, and then also people who had ART, so, and then the last group is people who had no infertility, and to look at those and see if there's a difference in the rate of cancer in their children. That's basically it. Anything on the methods you guys want to expound upon, especially Dr. Liao, I'll start with you.
There are many of them, and I would say there are many of them. When I dissect a paper, I guess, Dr. Chappelle, you have this experience too. When I approach a clinical epidemiology paper, I look at it from certain angles that coming together is basically a framework. One of that, which is very prominent in this paper, is multiple comparisons. I think one of the dangerous things in this situation is, while the authors admitted in the method section that the multiple comparisons were not accounted for in their statistical analysis, and therefore the results need to be interpreted as exploratory, that often goes away pretty easily, especially when the readers, the statistical laymen, are looking at this JAMA paper with huge impact factor. They very often get lost. But if you pull up their supplementary tables, they attempted 90 different comparisons for their primary analysis. So to help everyone make sense of that, when we say alpha is set at 0.05, or we are giving 95% confidence intervals for statistical analysis, what it means we are confident that the true value that we are trying to estimate will be covered by this interval 95% of the time. And so if we see a value that's actually beyond that interval, that is statistically unlikely, and therefore it is reasonable to reject our hypothesis, which is a null hypothesis. So we can reasonably say that must be a difference. But if we say we're attempting 90 sets of different comparisons, and we are setting a 95% confidence interval for each of them, what is the probability of all these intervals covering the true value without just getting there by chance? So it means we have to times 0.95 by 0.95 and do that to the power of 90. And then if we subtract that from 1, that gives us the actual chance of us actually hitting something purely by chance. I have done the math in this case. If you do 90 sets of comparisons like they do, 99% of the time you will hit something by chance. Not to say that they got to 3 hazard ratios that seem to be quote-unquote statistically significant. That could have come up just by chance. And they didn't do any statistical analysis technique to address that. They also were not candid about the number of comparisons were actually attempted.
Okay, well, so about 99% of that went over my head, but I think it raises an important point. I do a lot of, I review a lot of papers, I read a lot of research. I don't do this kind of paper, and in fact, if this paper was sent to me for review, I would say no, because I'm not qualified to review this. I would send it to you. But I think, go ahead.
I want to say I have done some national transplant registry analysis with some transplant surgeons and Johns Hopkins. And it is very common in national registry data analysis that you hit something statistically significant just because you have a gigantic database. But also look at that data. The hazard ratio derived from frozen embryo transfer, looking at cancer risk, came from just 14 cases of cancer in 3,300 plus children born after frozen embryo transfer. And when that happens in such a gigantic database, you only have 14 cases of cancer in a gigantic cancer database, that should always ring a bell.
I think it's important that when we read papers like this, especially for people like Jillian and myself who don't have the experience that you do, that we have to trust that somebody who knows what they're talking about read this paper and reviewed the stats on that, and then we have to just implicitly trust that they're correct and then go with their conclusion. I don't know, Jillian, do you have any thoughts on that?
Well, I think that the people who are approving articles for publication like the idea that this is a catchy title, that frozen embryo transfer increases the cancer risk. It's going to sell papers. It's sexy. It's something that they want to publish. So I think that they are maybe less motivated to make sure it's credible research because it's going to help JAMA look like a good paper worthy of reading.
That's definitely the cynical interpretation of that, and it's probably not far from the mark. But, I have definitely, I've reviewed papers and said they have to be, they need further statistical review that I'm not capable of, and I don't know what happens once I send that back to the journal, but I hope that they actually do that. So let's, as Dr. Liao, you already started mentioning, why don't we go into some of the results, and then you can definitely come up with where you thought they could have done something better.
Yes,
so they did look at one. Absolutely. So there were 1,085,172 children with 12.2 million years of follow-up, and they followed people to either cancer diagnosis, death, or to the end of the study, which was in 2015, I think. So they found that there were 16% of children were born to women with infertility. 51% of those were born after fertility treatment. So that means that 8% essentially had a history of infertility but didn't have any treatment, conceived naturally. There were 2,217 cancers. So out of 1 million children, there were 2,000 cancers. 30% leukemia, 11% lymphoma, 24% were CNS, 6% were sympathetic nerve tumors, and 29% were other, which I did a little research. It seems to be about average, so nothing surprising there. Going into the demographics, and this is where I actually have a couple of concerns as well. The women who were, required fertility assistance, they were... most of those babies were born in later years of the study, and so you could say about different IVF techniques, and I'll stop here for a second, actually, and ask Jillian. I'm going to guess that in the last 10 years, and this study went from 96 to 2015, that the state of, IVF has changed dramatically in that time.
Yeah, absolutely. But what I think is something they don't really comment on a great deal is that the drugs that we use for IVF and for frozen embryo transfer are almost the same. The difference is the cryopreservation. So if you're saying that the reason for the leukemia is related to the cryopreservation, sure, you might have an argument there. But in order for someone to go through a frozen embryo transfer, they necessarily have to have gone through IVF. And those embryos were necessarily exposed to the same medications that the IVF patients were exposed to. So it's hard for me to, they in this paper act as though those are completely two separate categories. IVF and frozen embryo transfer are completely two separate categories, but the medications required to undergo those processes are almost identical.
Right. So there's some confounders there. Yeah. The people who got fertility treatments had smaller babies, and they were more likely to be the result of multiples. Again, what does this mean? don't know, but they're certainly confounders. And Dr. Liao, we're going to come back to you on that in a second, because they kind of briefly mention how they tried to deal with their confounders, and maybe it's in those 90 things in the supplement. The mothers were more likely to be older and more educated, and the same thing for the fathers. And that actually is one of my concerns as well. Age, especially age of the sperm and age of ovaries, should be linked to, and definitely to aneuploidy. And since they mentioned in the introduction epigenetics, it may be linked to that as well. And again, that's not something they really touch upon, but maybe it's in their supplement. And then for cancers, they found no difference in cancer rates with infertility, no difference with fertility treatments or drugs, no difference with ART. But then, this is where they broke it down to the people who had frozen embryos, and they had 3,356 children born to frozen embryo cycles. And this is actually interesting, Jillian, I want your opinion on this. They had 30,000 frozen embryo cycles with 3,000 children, which is like a 10% success rate with frozen embryos. Does that sound right to you?
That's very low. The average in the U.S. is 50% success for each, 50 to 60% for each embryo. So it's very low.
Yeah, I was really surprised when I read that. So I don't know. Yeah. So again, I don't know. Maybe that was, how long have they been doing frozen embryos transfers, Jillian?
Oh, I mean, decades.
All right. So I don't know there. And then when they broke that down, of those, there were 14 cancers in the 3,000 children, so an incidence of 44.4 per 100,000. But again, there were only 3,000 children there. And as opposed for the fertile or non-infertility couples, and that was 17.5 per 100,000. And then for any use of ART was 21 per 100,000. And so they said that this was an increase, and it was all mostly leukemia and nervous system tumors. But Dr. Liao, as you said, 14 out of 3356, if you didn't know the 3356, maybe those numbers would go away. So anyway, that's basically what the paper says. That those are the results. And now I think I want to get down into, Dr. Liao, and what your issues are with the paper, and especially what analyses you wish they had done but didn't.
Yes, first of all, coming back to the issue of multiple comparisons, which I think is the most fatal issue, I think I can cite an interesting and amusing example. There was a paper published in 1991, and it was just basically a joke, trying to teach people why they cannot believe in results coming from multiple comparisons. And there was a team in Australia, in Melbourne. They did some research in if certain letters in the azoospermic men's surnames could predict live birth. And they looked at all the 26 letters, and they came up with the conclusion that having G or Y or N in the azoospermic men's surnames could predict pregnancy, and they call it GYN positive. And it is absurd enough that anybody can tell that this is a joke, this cannot be true, but I think it is a very vivid example of how detrimental multiple comparison can be to the validity of statistical analysis. Coming back to this example, there are many different techniques to address multiple comparisons, and one of the most conservative approaches is what we call the Bonferroni correction. For example, if you're going to plan for 3 comparisons in your paper a priori, our recommendation would be to divide 0.05 by 3, and therefore your alpha for each comparison won't be 0.05. It will be maybe 0.016, and so you're going to report 98-something% confidence interval, not a 95% one. And that makes it harder for you to call something statistically significant, and that protects against type 1 error. But the authors didn't really do that, and of course they were also not just doing 3 sets of comparisons, they were attempting 90. And in fact, for 5 of those comparisons, the numbers were so low, despite the database was so gigantic, that they couldn't even come up with any hazard ratio estimate, because the model will not converge if you have too few events. Because I think one thing that people need to understand is that your statistical power depends on how many events of interest you have. It doesn't matter how many individuals you have in your database. It depends on how common the event is. So if you're looking at some extremely rare cancers, it doesn't matter if you have the whole country's data. You just cannot come up with an estimate. And I would say the second major issue is confounding. Confounding, at the end of the day, is a matter of how exchangeable your comparison groups are. So in the primary analysis, what was being compared was completely fertile women versus women who have been through various different treatments. If we look at the comparison between completely fertile women versus women who achieved pregnancies after frozen embryo transfer, they differed in so many different ways. They differed in their diagnosis of infertility. They differed in the drugs, the ovarian stimulation, the retrieval, the embryo creation, cryopreservation, thawing, and transfer, that I don't think it's fair to only adjust for the calendar year in 5-year intervals, because these women do not just differ by the calendar year when they gave birth. The author did comment on how many of these treatments and drugs in and of themselves do not seem to be associated with childhood cancer independently. But if you see a statistical association between the two of them, and if they conceptually play a role in this whole conceptual framework, are different. They also mention because these variables did not change the effect estimate by more than 10%, they can just drop them from the models. And I would say that's not appropriate either, because I think what makes a difference between legit clinical epidemiology and data mining is clinical epidemiologists would actually plan the analysis based on a conceptual framework, not just looking at the numbers. There are other things. For example, what was captured in Table 1 or the entire paper was the age when the women gave birth. But we know the embryos could have been frozen years before they were transferred back, and then the women got pregnant and they gave birth. So it is very inaccurate to use the age when the women gave birth as a surrogate of when the embryos were created, which matter more. And in fact, there were data showing that parental ages, not just maternal age, but also paternal age, was associated with pediatric cancer. And so I think that paternal age alone conceptually should not be dropped from the model either. Also, look at donation cycles. Nowadays, we do lots of egg and sperm and embryo donation cycles. If we look at the CDC report on the 2016 data, I think as much as 5% of the cycles involved the planned use of donation, actually 9%, to correct myself. So it is, first of all, I don't know what exactly the number is in Denmark, but I would assume in the current era it is a pretty sizable number, and to just completely neglect that fact is a pretty major issue. And there are other things, for example, statistical significance. I know you say statistically it is significant, but how much does that translate into the reality? Because if I say there is a twofold increase in the risk, but that means 26.9 additional cancer cases for 100,000 children. I think this, Dr. Chappell, you have talked about many times in your podcast, because if I calculate the number needed to harm, that comes up to 3,717.5 frozen embryo transfers have to be just forgoed to prevent one maybe dubious childhood cancer. But if we think about the benefit of frozen embryo transfer, which I think Dr. Kurtz has more knowledge on than I do, we know frozen embryo transfer gives us unprecedented flexibility in ART treatment. It drastically reduced the risk of ovarian hyperstimulation syndrome. It drastically reduced multiple pregnancies. It gave us the opportunity for embryo banking, which contributed to 25% of the ART cycles in the US in 2016, and also pre-implantation genetic testing, which is very hot these days. And so I think it is an unfounded claim overall, what these authors have described. There are other issues in the discussion session because they were trying to defend how their findings were plausible. And so they said they looked at 4 previous studies who looked at the association between the use of frozen embryo transfer and childhood cancer. 3 of those studies found no statistically significant associations. However, one study reported an elevated hazard ratio for any type of cancer. And then they put out what they said elevated hazard ratio was 1.8, but the 95% confidence interval absolutely crossed 1. And the way they phrased it said elevated hazard ratio, I think is very misleading, because I think if your hazard ratio crosses 1, you cannot say there's an elevated hazard ratio. Just like Dr. Chappelle, you said, you cannot make a claim there's a trend of elevated hazard ratio. It is either yes or no.
Agreed.
And this is just some of the complaints that I have against this paper.
Can I chime in and complain a little bit myself? They in the discussion section, they're trying to give supporting arguments to say why their findings are plausible. Why does the frozen embryo transfer maybe contribute to leukemia risk? And their arguments are just so weak; they don't even make sense. They talk about how a frozen embryo transfer uses estrogen, and that they're going to be on estrogen for 10 weeks, and estrogen is a human carcinogen, but the doses of the estrogen that we have women on for frozen embryo transfer is pretty comparable to what women do for oral contraceptive pills, and they're on oral contraceptive pills for years and years and years. So it's just not a great argument to say that 10 weeks worth of estrogen is enough to cause leukemia in offspring down the line, to me.
Yeah, I really liked when they called progesterone classified as reasonably anticipated to be a human carcinogen. I was like, well, if that were true, every woman would have cancer, but that's a different story. I know. Yeah, I certainly was not a big fan of the paper, but I think I want to bring it back to two bigger points that are bigger than this paper, and I think maybe 3. One for me is big data and how we use big data to look for these sorts of things. All a database like this can do is say that 2 things are associated. They cannot say that they are causal. And I think when we write papers like this that use big data or registries, whatever it is, we have to be very careful with how we phrase things, because we're used to phrasing things like, "Oh, this is I don't know how to say it. They do say associated, but we have to be very careful to say that does not mean they're causal. Like, we're not even doing a randomized control trial with 2 things. We're trying to control everything to make sure there's no confounders, and then we see a result that they're associated. We can say, okay, well, those 2 things may be caused, may be linked. In a big database, we can't really say that. None of those confounders are really controlled for that well. I think Dr. Liao went through very, very, very well there. So with these kind of studies, I do worry about how we phrase things and about how the people who are reading it understand it. I don't know if Dr. Liao, you may have some thoughts about big data and how we write that stuff.
I think there are certain things that we have to rely on big data, because there are certain things that we cannot randomize because of logistical reasons or ethical reasons. And for example, for generalizability's purpose and for how representative your data are, and for power reason, there are things, for example, ART T and organ transplantation, which will benefit from big data analysis, I think is more how we need to educate ourselves and educate physicians who are not as involved in research and our patients the very fundamental and basic statistical literacy. I believe I can say that is as important as making vaccine very accessible and popular to prevent disease, because I think misbeliefs and misinterpretations are diseases. And so we have to educate them all. I think there are very good stuff that can come from it. For example, if this study was properly done, if we can adjust certain statistical aspects in how they did the analysis, it could have given us more valid interpretation, and it could have given us reassuring information for patients. Because over half of the cycles in the United States in 2016 involved frozen embryo transfer. And that is a very big number of people to consider. I think right now, instead of giving them reassuring information, which I believe we will get if we actually did the correct analysis, instead of that, we are subjecting all these families who conceived their children after frozen embryo transfer and now were diagnosed with childhood cancer. We are subjecting these parents to undue stress, guilt, and anxiety because of some unfounded claims. We are also subjecting millions of patients worldwide who have undergone frozen embryo transfer or are planning to do so to stress and anxiety. And I think that is truly terrible, because if we look at what the media have said, how they misinterpreted and throw out alarming titles, I think that's just one of the unfortunate cases, just like how many things that we used to do in medicine, we no longer can do them, not purely because of medical evidence, because how science was misinterpreted. And I would say the authors definitely phrased that they were not trying to imply causation. However, there are places in the paper where they definitely implied it, at least to the statistical layman, because they said, quote, compared with children born to fertile women, the cancer risk increased among children born after the use of frozen embryo transfer, end quote. And then they said, quote, children born after the use of frozen embryo transfer had a statistically significant higher risk of leukemia and sympathetic nervous system tumors than children born to fertile women, end quote. And I think it's hard to say neither of these statements imply causation. They really sound convincing.
Yeah, I mean, I think you raise a good point. I mean, this was picked up by CNN, and the first line of the CNN article was, children born after the use of frozen embryo transfer were at higher risk of childhood cancer. So people are reading that, and I'm sure that Dr. Kurtz here will be getting some patients coming in at some point and asking about this. And that's a good question then. So how are you going to deal with this, Jillian, when someone comes in and asks about it?
Well, I think I would go into, let them know that I don't necessarily trust the findings in this paper and briefly explain that. But I would also reassure them that even though it doubles the risk, in quotes, it's still exceedingly rare. So, when you're doubling a risk that is only, I can't remember what they said the actual risk was, but it was already exceedingly rare, and then you double it, it's still exceedingly rare. So even if you did think that there was some association, I would just provide reassurance. And like Dr. Liao mentioned, there's so many benefits to doing the frozen embryo transfer, and we actually think that the pregnancy rates and the live birth rates are better with frozen embryo transfer than they are with live or with fresh. So I think I would encourage them to do it for all of those reasons as well.
Okay. I do want to make a correction. I said that there were 30,000 embryo cycles. I don't know where I got that from. I was reading a wrong number there. So they don't actually say how many embryo cycles there were. So I take that back.
Yes, I would say we actually have a paper in the pipeline to try to fight back the literally nonsense coming from this paper. I would say the statistical analysis has so many problems that I don't think the risk actually even doubled. Because that twofold hazard ratio might not even actually exist.
Right. So that leads me to my last question. I guess it's Dr. Liao, I suppose. But so papers like this. So if you're doing a paper, you want to submit it and get it published. You have to use the different protocols you have to follow in order to, you have to show that you followed them. Now for epidemiology papers, I don't know if something like that exists, but it would almost be nice if there were one centralized body organization that was responsible for reviewing the statistics for papers like this in epidemiology, because I can tell you as a reviewer for AJOG, they have their own statisticians that you can refer to, but if they send me this paper, I don't really know enough stats to say yay or nana. And even sometimes I'll get a paper that it's not like this, but the stats are a little more complicated than I'm used to dealing with, and I will say, it looks okay from what I know, but you should have it reviewed by an epidemiologist or someone with a master's in epidemiology or statistical stuff. So I don't know. What's your thought on that, Dr. Liao? Is there a movement like that already? Are there guidelines people have to follow when they do these papers?
I know there are very gross overall guidelines for different types of studies. For example, there's the STROBE system for observational study, and there's the PRISM for randomized controlled trials. But I think when it comes down to the nitty-gritty details of statistical testing, most clinicians won't be experienced enough to tell. But I think in general, just for all of us, and the very basic things, for example, think about the population, if there's any selection bias, if it's generalizable to your population or to other population, if there's any bias, if there's mediation, meaning something have been a mediator in between, or multiple comparisons. And it's always good to think about missing data, which is very common in clinical research, and type 1 as well as type 2 errors. And it's also always good to think of different scenarios and have some sort of sensitivity analysis to show that you can obtain consistent results. These are the criteria that we were taught to follow when we critique a paper. But I am not aware of any formal body or organization who essentially assign the tasks to critique all these papers statistically.
Yeah, that's too bad because they're so complicated that they really need to be done. There's probably a few hundred to a 1,000 or so people who have the specialization and the knowledge to really critique a paper like this and ask the questions that you asked. So it'd be nice someone to have like a stamp of approval. This was reviewed by the experts, and we agree with what they did. Even if we don't care about their clinical stuff, but we agree with the way they approached it.
I would say though, most of the lay public should be, and I understand this is very ideal compared with the situation these days, but I think most of us should be able to tell at least when people are taking a shotgun approach and doing multiple comparisons, there needs to be a problem, even if you can't pinpoint like I do go into the math and come up what the exact percentage is to find something by chance. I think if you see someone is attempting dozens or 20s or 30 sets of comparisons, there should be a problem. And when it comes to confounding, it sounds very statistically sassy, but it really comes down to if the groups you're comparing are exchangeable. If you think you are comparing apples to oranges, an analogy I often use is, in reality, we can't randomize patients to treatment all the time like we do experiments on mice. So we have to do certain compromise. Sometimes we use statistical testing, and if you properly do it, then maybe you are at least comparing grapefruits to oranges. But if you know these two groups are drastically different and you only adjust for one tiny little factor in between these two, you are comparing dinosaurs to oranges. And in this case, It doesn't matter what kind of p-value you get, it's just not valid. So I think I think most clinicians can tell if they are comparing something that's very different. I also think, and I don't know if you guys have heard about Bradford Hill. Bradford Hill is someone that I really respect. He was one of the two. He, together with Richard Dole, published the paper on the association, actually causal relationship between cigarette smoking and lung cancer in 1950. And he proposed 9 features of a causal association. And he was a big proponent for researchers to speak in the language of clinicians and laymen. Because if, as a researcher, you are just playing with numbers in the language that nobody else can understand, the science cannot go far. So I think my experience is also, I can do a lot of things fairly in a very sophisticated way, but I don't always go that far along that line, because I know once reviewers cannot understand what you're saying, your paper won't be accepted.
Yeah, absolutely. I think you have a very ideal version of what residents are taught as far as research. I don't know, Dr. Kurtz, did you have a robust statistical education in your residency program?
No, I wish. And even still in fellowship, I have to say I'm guilty of oftentimes, I read the methods section, but if there's something that I don't understand, I just kind of skim through, and I trust that the reviewers of the paper must have, thought that it was legitimate research that was worth publishing. So I am a little bit skeptical now that I'm hearing Dr. Liao sort of criticize all of this statistical analysis. I'm wondering how many papers have I read that I should have been more critically evaluating whether or not I can trust the results.
Yeah, probably most, and we're all guilty of doing the same thing, Dr. Kurtz, so don't feel too bad about that. I guess my point is, it's one thing to even do a course on statistics, and I've done several, and to learn these things exist. It's another thing to do what you did, Dr. Liao, and actually live those statistics on a day-to-day basis, because that's when you really internalize where there are problems and when to trust it and when not to, and when something doesn't quite look right. And you only really know that if you live it and use it and breathe it. And so I think it's probably unrealistic to expect our clinicians to really do that, especially then not even our medical journalists, because they're one step removed from that. So I don't know. The whole part of reviewing a paper and then getting it up there and people reading it, interpreting it, the whole thing is fraught. The whole system, I don't know, is that great. And to be fair, I'm part of the system because I'm both an associate editor for a journal and a reviewer. But I don't know. To me, there needs to be something different for all the reasons that were said tonight. But in any case, any final thoughts on this paper? Anything you're going to take home besides the fact that don't trust the statistics, and hopefully people aren't going to start getting super anxious that all their children are going to get childhood cancer now? Any other thoughts? I'll start with you, Dr. Kurtz.
No, just when I look at that these aren't clinicians that are publishing these papers, it makes me wish there was more time for clinicians to be able to devote to research, but we're so focused on making money, or we have to be focused on making money because of the institutions that hire us on, and you're not really allotted as much time as you need to be able to publish meaningful research. And so then it's left to the academic scientists, which is all well and good, except that you don't know the significance of those findings if you're not really a clinician.
That's a good point. And Dr. Liao?
I think in this era, when information comes out so quickly through the internet, for medical students, residents, a larger part of their education should be dedicated to the very, very basic scientific or statistical concepts. They do not need to know how to use statistical software. They do not need to tell me when to use a t-test, when to use a non-parametric test. But I think it is really important for them to know all the basic concepts that I just mentioned. When there are such obvious problems, they need to be able to recognize, because they are the gatekeeper, or we are the gatekeeper of research information for our patient and the society. I think it is so impactful that we cannot just let it go.
Absolutely agree. We definitely need to do more. We're trying to incorporate some more into our residency program here. But I agree with you, the point of journal club and residency, the point of this journal club, the point of doing research in residency is not the research itself, but it is to learn how you go about research and where the issues lay, and the issues that come up when interpreting data. So when you read someone else's paper, you can say, I'm a little suspect of how you did that here because I know how hard it was when I tried to do it. That should definitely be the goal of resident research, not necessarily publishing, although that's nice too if it happens. All right, well, thank you two very, very much. This was the Journal Club for January 2020. More shows on the way, and a Happy New Year to everyone. Thank you both for coming.